Welcome to the CARPHA BSEC webinar series on research ethics. My name is Derrick, and this is the 5th webinar in the series. The series began on February 25 with the topic, The Importance and History of Research Ethics, by CARPHA's Regional Advisor on Bioethics, Dr. Carla Sainz, who also presented the following week Wednesday on the topic, What Makes Research with Human Subjects Ethical. On Wednesday, March 11, I did the case discussion of what is research, and last week, Professor Cheryl McPherson, the President of the Bioethics Society of the English-Speaking Caribbean, did a case discussion of the topic, Problems in Research Design. Today, I will be doing a case discussion surrounding the issues of harms and benefits. Research with human participants always raises ethical concerns, because whilst the main aim of medical treatment is to benefit the patient that is being cared for, the main aim of research is to benefit others. The knowledge to be gained from the research is to be used for the wider society, and not necessarily in the best interests of those enrolled in the particular research endeavor. When we think of all of this, we can see why this reality places a huge obligation on us to ensure that these altruistic research participants do not come to any harm, or that harm is greatly minimized. The ethical principle of justice denotes an ethical concern for fairness, equity, even-handedness, impartiality, and justice, and justness of grounds, reasoning, dealings, and treatment. To achieve all these goals requires a positive, beneficial balancing of possible benefits versus possible harms. Ethical questions arise even in ideal circumstances. In these ideal circumstances, persons may be enrolled in the research and they stand to gain personally from the research, such as them receiving improved health care or something similar, and certainly that they will suffer no harm. For example, if a study involves a potential benefit for participants but little risk of harm, the number of persons who wish to participate might be more than the study can accommodate. This raises questions of justice. Who should be chosen for participation, and what factors should be used as justification for choosing among individuals or groups? A promising drug, or even a slightly better access to personal health care, are both very good reasons for persons to seek participation in a research study. And investigators should have defensible grounds for the choices they make among prospective enrollees. For example, on the matter of fairness, is there an ethical justification for excluding women of childbearing age or people who are HIV positive from the possible benefits of the trial? Reasoning along the same lines, why should one community be chosen as a research site and not another? These are questions that research ethics committees need to consider during the review of research protocols. Other benefits-related questions include, who will benefit from the knowledge gained? Why should the limited resources available for research be used to learn about one disease rather than another, or about the health problems of one group instead of another? Is it ethical for sponsors to reap large benefits in the form of patents and profits from drugs that are proven to be effective through research trials, even if the knowledge gained does not eventually provide benefits to the population from which the research participants came? Justice is the distribution of benefits at the completion of the research study, and this should always be considered. In research that involves a possible risk to participants, a study's potential harms are generally required to be less than its expected benefits, which include the benefits of the new knowledge to science and to society. The most challenging moral dilemmas about risks and benefits occur when participants are placed at risk of harm or are burdened by discomfort or distress without the prospect of any personal benefit. In such cases, the Research Ethics Committee must decide whether the expected burden on participants is justified by the prospective benefit to others that could result from the knowledge gained, and whether participants will be appropriately compensated for any harm they could incur by taking part in the research. There are no easy answers to the question of how research ethics members should reach these balancing judgments, and such moral balancing is perhaps the central task of research ethics committees. Indeed, in accounts of previous research abuses, the offending scientists have often clearly overemphasized science and the benefits to science at the cost of participants' well-being. In many studies, all participants feel the possibility of harm, distress, or discomfort. For example, in the early phases of testing new drugs, that is in phase 1 and 2 clinical studies, investigators must prove the maximum dose of the experimental drug that human beings can tolerate. As they near such limits, some participants might be harmed or experience discomfort. However, because these early studies are either carried out on healthy volunteers or are being tested for the first time in patients, participants are not expected to receive any corresponding benefits. Even in later stages of clinical trials, the possibility of adverse reactions and adverse outcomes cannot be ruled out, and positive consequences cannot be assured. Research ethics committees, therefore, must ensure that possible harms are minimized and are outweighed by possible benefits, and that the potential participants will be given a full and honest account of the harms and benefits that they could experience before they agree to join a study. If conscientiously carried out, the consent process should permit prospective participants to weigh the potential for harm against any prospect for benefit. We should note that potential harms and benefits might be difficult to compare because of uncertainty, as they could affect different people in different ways, or because the harms and benefits are of different kinds. For example, pain versus extension of life in a test of chemotherapy for cancer. This complicates decision-making for individual participants, but research ethics committees must also judge whether the net prospect for participants will be negative, that is, potential harm or discomfort is greater than the corresponding benefit. This might also occur in studies that do not have any therapeutic aim for participants. For example, studies of new diagnostic tests or research on the biological basis of diseases. Sometimes investigators find emerging trends for the success or failure of the drug that they are testing, and they find these so compelling that they face a dilemma about whether or not to continue the trial. In the past, some investigators did decide to stop a trial early, so the treatment being investigated could be made available to participants in the placebo group as well as to other patients who might benefit. With the double-blind designs now commonly used, a decision to end a trial early usually rests with an independent Data and Safety Monitoring Board or committee, which has access to the accumulating results of the trial on an unblinded basis, and which is guided by stopping rules made up in advance of the trial. A DSMB may end a trial prematurely because statistically significant results have been achieved before the number of research participants originally planned have been enrolled. Alternately, it may call off a trial because the pattern of harm, either to the active or to the control group, is both greater and clear, even though not yet statistically significant. This therefore means that the result or outcome of the trial will be unknown. Research ethics committees are often required to make a decision about whether the results that the proposed study could produce are worth the burden or risk to participants. Also, sometimes committee members must determine whether the potential outcomes from a study whose design may carry some risk are better in scientific terms by a margin that is significantly greater than the results that could be expected from a less burdensome or less risky design. At other times, research ethics committee may have to decide whether to trade off scientific certainty in favor of protecting participants. For example, a study design might be satisfactory or even optimal in scientific terms, yet might impose a burden on research participants that could be avoided or reduced by using a different design. If the alternative design is capable of producing results that are scientifically equivalent, then this alternative design, which lessens the risk to the research participants, is ethically mandated. Consequently, members of research ethics committees should be familiar with the various types of research study designs. Sometimes research design questions may be decided based on a balance of ethical considerations. For example, should a study be undertaken that involves 20 consenting participants to a substantial chance of physical harm, if the same results could be produced by an alternative design which has a much smaller risk of causing harm to individual participants, but which requires the enrollment of not 20, but 2,000 participants. Think about that. Likewise, should a new vaccine be studied first in older teenagers who are capable of giving consent, and then in younger teenagers who are capable of providing assent but not valid consent, in order to develop greater certainty about its safety before it is tested in the infants for whom it is intended, but who are too young to give even assent? How can potential harms and benefits of various types and magnitudes to different people simply be summed up arithmetically? One study design might be able to provide data that would conclusively confirm or disprove a research hypothesis, while an alternative design that would impose fewer burdens on research participants is likely to produce less definitive evidence. What if such less definitive scientific evidence is not enough to allow a disease to be diagnosed or treated with any certainty? What if the disease under consideration can cause death if not diagnosed or treated? Does one's conclusion change if the disease is only mildly incapacitating but not crippling or fatal? What if this disease kills children and not adults? As these examples make clear, once one accepts the scientific design does indeed cause ethical issues, one might have to balance values from these competing possible domains of research activity. So, are there times when it is not useful to simply compare harms and benefits? In which case, judgments about the ethics of a study must rest on other grounds. Balancing risk and benefits are complicated still further when potential harms and benefits accrue to persons other than those enrolled as participants. For example, one concern regarding xenotransplantation, in which animal organs are transplanted into human beings, is that organs could contain hitherto unknown retroviruses that could cause and could spread to the human population in a way similar to HIV. Should research ethics committees take such potential harm into account? Or is the research ethics committee's purview limited simply to the welfare of the study participants? Research ethics committees must therefore ensure that possible harms are minimized and are outweighed by possible benefits, and that potential participants will receive a full and honest account of all the harms and benefits that they could experience. Now, the issue regarding what should concern research ethics committee, it may arise only rarely in connection with infectious diseases, but arises more commonly for groups that could be or could consider themselves to be adversely affected by the publication of a study's research results. For example, the results of genetic studies can have implications for close relatives of participants. Similarly, in a study of HIV prevalence in several South Asian villages, some residents there feared that because the identity of the towns could not be adequately masked, the studies would stigmatize all residents as HIV positive. Should such concerns and considerations fall under the purview of research ethics committees? Let's now look at the case for today's discussion. For this case study involving harm and benefit, it is taken from the case book on ethical issues in international health research written by the Pan American Health Organization, and it involves the rotavirus vaccine. Now, rotavirus is one of the most common causes of severe diarrheal disease and dehydration in infants and young children in both developed and developing countries. The virus, which infects almost all children by the time they are aged 2 to 3 years, appears to be as prevalent in high income as it is in low income countries, despite wide differences in the functioning of their sanitation and healthcare systems. The difference in income level is instead manifested in a marked difference in the morbidity and mortality rates associated with the virus. Of the estimated 527,000 rotavirus deaths per year worldwide, most are among children aged younger than 2 years, and most, up to 85%, are in low-income countries. The observation that rates of illness caused by rotavirus are universally high among children in both developed and developing countries indicates that making water supplies clean and following good hygienic practices will not markedly decrease the incidence of rotavirus in developing nations. Therefore, further improvements in water or hygiene are unlikely to have any substantial impact on preventing the disease. For this reason, and because the heavy worldwide burden of disease caused by rotavirus, immunization by vaccine would be an important public health intervention in both developed and developing countries. Based on the findings of 4 randomized controlled efficacy trials in the United States of America and in Northern Europe, in the late 1990s, a North American national drug licensing body licensed the quadrivalent rhesus rotavirus vaccine, RRV-TV, for routine vaccination in its own country. Following that licensing, about 1 million children received the vaccine. Within a year, the number of reported cases of intussusception, that is, the bowel telescoping into itself, cutting off its own blood supply, and potentially leading to obstruction and, if untreated, death, among infants that were vaccinated with RRV-TV, estimated at 1 case per 10,000 children vaccinated, raised concerns. The U.S. Department of Health began to analyze reports from the system set up to monitor and provide post-licensing surveillance of adverse events after vaccination. In the report of its findings, the Department of Health stated that the data raised strong concerns about the relationship between vaccination and RRV-TV and intussusception. Consequently, the department recommended that administration of this vaccine to children should be postponed. A few months later, the manufacturer of the vaccine voluntarily withdrew it from the North American market, which was interpreted by many in developing countries as a sign that the product was unsafe. There is a view, however, that in developing countries where the burden of morbidity and mortality induced by rotavirus outweighs the risk of serious morbidity from the vaccine. If the vaccine is found to be effective, the benefits of the vaccine therefore outweighs the risks. According to this view, the scientific community is therefore equally responsible for deaths that are caused by withholding the vaccine, as it is for deaths caused by the vaccine itself, as it is unethical not to continue randomized controlled trials of this vaccine in developing countries. Indeed, not doing such studies would perpetuate global inequalities in access to health care. The Ministry of Health of a developing country compares the risk of a child younger than 2 years dying from rotavirus diarrhea, which occurs 1 case in 100, with the risk of a rotavirus vaccine-related death, for example, from interception, which occurs in 1 in 10,000 vaccinations. The ministry concludes that, if affordable, the vaccine should be given to all children within the first 3 months of life. The ministry then directs a well-respected state-run pharmaceutical company, LDC Pharma, to obtain the production techniques and rights from a North American manufacturer for local production and distribution. LDC Pharma consequently assures the Ministry of Health that it can produce the vaccine at an affordable price. The North American company, however, refuses to transfer its production techniques to LDC Pharma, even after LDC Pharma assures the company that it will not sell or distribute the rotavirus vaccine outside its own country. The North American company notes that it wants to recoup the almost $150 million that it spent on developing the vaccine, and expresses concern that it could potentially be held liable should any complications be associated with the vaccine. Despite the North American company's refusal, however, LDC Pharma could possibly obtain the vaccine production technique by invoking the concept of compulsory licensing. This clause, however, can only be invoked under special conditions and only if the authorization meets certain requirements. This now leads us to the questions that we have to consider for this case discussion. Question 1. Assuming that the vaccine is the cause of at least some of the cases of interception, should the vaccine be administered in settings where rotavirus is a significant cause of morbidity and mortality in young children? And the second part of this question, is there an ethical difference between exposing a sick population of children to a possible complication that can cause death versus a healthy population of children? Question 2. Is there an ethical difference between exposing a population of children that is at a higher risk of dying from, in this case, rotavirus, due to a possible fatal complication from a vaccine, versus a population of children that normally does not have any serious morbidity from rotavirus infection? Question 3. What degree of risk is acceptable in this case, and who should make that determination? Question 4. Is a North American manufacturer under any moral or ethical obligation to allow the developing country to produce the vaccine for local consumption? And question 5. If the North American manufacturer refuses to either produce an affordable rotavirus vaccine for developing countries or give up its patent rights so that it can be produced at a much lower cost in a developing country, are these countries under any moral or ethical obligation to honor these patent rights? We should consider that the World Trade Organization Agreement on trade-related aspects of intellectual property rights, which will in certain circumstances allow WTO members to issue temporary license against the will of the patent holder. And so, let's do an analysis of this case. I'll be inviting you to type in your responses in the bottom left-hand corner of your screen. so we can proceed with the discussion. So let's look at question 1. Assuming that the vaccine is the cause of at least some of the cases of intussusception, should the vaccine be administered in settings where rotavirus is a significant cause of morbidity, which is sickness, and mortality, which is death, in young children? What are your thoughts? Please type your responses in the bottom left-hand corner of your screen. Assuming that the virus is the cause of at least some of the cases of intussusception, should the vaccine be administered in settings where rotavirus is a significant cause of sickness and death in young children? What are your thoughts? Responses: yes, it helps the greater good in the developing countries. Yes, subject to checks and balances on international standard. In this case, yes. If there are facilities available to adequately diagnose and manage intussusception, then yes, the benefits may outweigh the risk. It's a tough decision, but I think most parents would rather deal with a sick child versus a dead child. I believe the less developed countries should be given the option to obtain the vaccine, fair enough. If most are likely to benefit, it should be administered. Yes, I think most answers are in this, following this trend of thought. So my answer is this requires a balancing of potential benefits against potential harms. There is no doubt that the vaccine should be administered in settings where rotavirus is a significant cause of sickness and death in young children. We should consider issues such as how many children are likely to benefit from such a prevention. And based on what's happened elsewhere, as well as the local statistics regarding the prevalence, the normal prevalence of intussusception among the general population, we should also consider matters such as how many of these children may experience this complication due to receiving the vaccine. So we are in accord with part 1. Part 2 of the question 1. Is there an ethical difference between exposing a sick population of children to a possible complication that can cause death versus a healthy population of children? What are your thoughts on this? Type in the bottom left-hand corner and give your reasons. Is there an ethical difference between exposing a sick population of children to a possible complication that can cause death versus a healthy population of children? I'm presuming that Claudia was answering part A of the question, where they said the vaccine should not be administered. It's an ethical issue. The sick population may need the intervention more. No, there is no ethical difference. Okay, so this is addressing part B. No, there are no ethical differences. All persons sick or not should be respected in the same manner and should be protected. Another thought: it is beneficial for sick population. The risk for the disease, if the risk of the disease for which the vaccine will provide protection is low in a country, then it should not be given. There is an ethical difference. Okay? So one person says there is no ethical difference, one says there is. Okay, I don't think there's an ethical difference. Exposure to harm is exposure to harm. Okay. Another one says there and this is what I anticipated. An equal balance of persons, so it will say yes there is and yes there is not. And that's important. I'm gonna show you why. One person, she and Campbell says, I believe there is a difference. The sick population is more likely to be exposed to harm given they're already compromised. I like that answer. Not sure. Fair enough, Indira. If ethical difference, we fine. Then this is okay. I get the general drift. Okay. So my answer. No. To part B of question 1, no. If we are comparing exposing a sick population to a possible complication that can cause death and a healthy population to a possible complication that can cause death, then both populations, sick and healthy, would be exposed to possible harm. And so the consequences, which is possibly dying, exist equally for both groups. So in other words, no difference would exist in the outcomes or consequences between the two groups. So ethics is about actions. And so when we look at the two populations, we're imposing a vaccine that carries risk of harm to both of them in equal quantity. So it doesn't matter if they're sick or healthy. They will both get the risk of interception. So there is no ethical difference there in your action. Let's look at question 2 now, which complicates it even further. There's a question, well, but Karen Lewis said, but wouldn't this be weighed against the risk of a disease versus the intervention? All right, we'll come to that in our discussion section, or perhaps that may be addressed when I give my answer for question 2. So let's consider question 2, Karen. Is there an ethical difference between exposing a population of children that is at a higher risk of dying from, in this case, rotavirus, due to a possible fatal complication from a vaccine, versus a population of children that normally does not have any serious morbidity from rotavirus infection? What are your thoughts? Type them in the bottom left-hand corner and provide your reasons. Is there an ethical difference between exposing a population of children that is at a higher risk of dying from rotavirus due to a possibly fatal complication from the vaccine versus a population of children that does not have any serious morbidity from rotavirus infection? Your answers. And I come back to Karen's point later on, if it is not addressed when we answer question 2. What are your thoughts on comparing and saying if there's an ethical difference between exposing these two sets of children to the vaccine? Okay, Karen says yes, there's an ethical difference. If the risk of dying from the disease is low and negligible, then the risk of complication of the vaccine would outweigh the benefits. Fair enough. Any other thoughts? Karen has expressed your thoughts. Any other thoughts on that? Or are you saying you're all in agreement with Karen? Okay. Professor Nayak says no, because in this case, treating the higher risk population is more important. Again, this depends on the percentage of risk population. Samantha says no, none of these children should be exposed to this. I think the harms outweigh the risks. Aberdeen says, oh, Celia, okay, fair enough, we're moving along. In the interest of time, I'm going to move on. My answer in this regard to question 2 is yes. Here, in this particular case, there's an ethical difference. The difference lies in carrying out an action, namely immunization with rotavirus vaccine, that carries a higher risk of a greater possible harm, namely death, in one population than it carries in another. The population that normally does not have any serious illness from rotavirus infection and so has little chance of dying from severe diarrheal disease and dehydration would now be put at a relatively great risk of dying, this time from rotavirus vaccine intussusception. So in this case, yes, there's an ethical difference. Hope that is clear. We can always discuss it afterwards. So we'll move on to question 3. What degree of risk is acceptable in this case, and who should make that determination? What are your thoughts of this? What degree of risk is acceptable in this particular scenario, and who should make that determination? So the responses before are referring to my previous question, and they are in agreement. Yes, yes, yes. Okay, Claudia says the Ministry of Health and REC, but Claudia doesn't tell me what degree of risk is acceptable. Professor Nayak says medium risk. Any other thoughts? What degree of risk is acceptable and who should make that determination? Janice says the risk of getting or dying from the rotavirus infection versus the risk of the benefit should be greater than the risk. Currently, it is less than 10% risk acceptable. Policymakers would make it medium to high risk, says Elizabeth. Kareem says Ministry of Health and Parents should make the final determination. Okay. My thoughts. The degree of acceptable risk in this case is low risk, and that determination should be made by the evaluating research ethics committee, because the research, I know someone said Ministry of Health, but because this research endeavor was placed for evaluation before the committee, then they would evaluate. But of course, we agree the Ministry of Health for the country has the ultimate responsibility. Now, why do I say low risk? First, let's look at minimal risk. Minimal risk is the least possible risk. It describes procedures such as questioning, observing, or measuring participants in a subject area that is not controversial, provided the procedures will be carried out in a sensitive way and that informed consent will be sought and given. Other procedures with minimal risk includes collecting a single urine sample or using blood from a sample that has already been taken as a part of a routine medical case management. Low risk describes procedures such as those that cause brief pain or tenderness, or small bruises and scars. Research endeavors that involve injections or venipuncture, that is, taking blood from veins, therefore generally fall in this category. So, as this case involves children and the procedure giving the rotavirus vaccine would cause brief pain and tenderness, then this category, low risk, would be deemed acceptable. Notice the difference. You're dealing with a large population of children who would then get low risk. It's just a small percentage, 1 out of 10,000 children would then get intussusception from this vaccine. So when we think of the population, subject population, and we think, okay, what are all the children who are involved going to be exposed to? They're simply going to be exposed to this vaccination, which causes brief pain and tenderness, but nothing else for them. So the entry category is low risk, not high risk. If it was just a small population that we knew all of them would be getting interception, then it would then become high risk. But for the large general population that's getting this, it's low risk. Just the brief pain and tenderness that the vaccine causes. And so, question 4. Is a North American manufacturer under any moral or ethical obligation to allow the developing country to produce the vaccine for local consumption? What are your thoughts? Is a manufacturer in North America under any moral or ethical obligation to allow the developing country to produce the vaccine for their local consumption? Capitalism says no. Okay, so we're dealing from a financial point of view. Okay, Karen says yes on the ethical obligation. So does Helene. Says yes. Yes. Highly unlikely. Should standard. Yes, yes. The majority seems to think that there's an obligation. So in the interest of time, I'll move on. The North American manufacturer is under a moral obligation to allow the developing country to produce the vaccine for local consumption. And we base our reasoning on this. The heavy worldwide burden of disease caused by rotavirus cannot be significantly reduced through improved water supply, sanitation, and hygiene. And immunization by vaccine appears to be the only viable medium through which a reduction in the morbidity and mortality of this disease is likely to be effective. This is supported by the view that the scientific community is equally responsible for deaths caused by withholding the vaccine, since in resource-poor countries, the morbidity and mortality that is caused to children by rotavirus diarrheal infection significantly outweighs the risk of morbidity and mortality posed by any possible interception resulting from administering the rotavirus vaccine. In simple words, the benefits of the vaccine outweighs the risks. So, if a North American manufacturer is concerned about the health and well-being of children and not only the financial aspects of vaccine production to help children, then the manufacturer should recognize this deeper moral obligation that binds us to reduce harm in our fellow human beings and to seek to reduce suffering because of our common humanity. Allowing the developing country to produce the vaccine for local consumption would achieve this end. And our final question for analysis: if the North American manufacturer refuses to either produce an affordable rotavirus vaccine for developing countries or give up its patent rights so that it can be produced at a much lower cost in a developing country, are these countries under any moral or ethical obligation to honor these patent rights? What are your thoughts? Yes, Colin, the WTO implications is that you can force the issue, but we are debating ethical versus legal, and we're not choosing to force using the WTO just yet. It will be up to the individual country to proceed, but as research ethics colleagues, we are debating to see which of the two will be preferable. But I do agree that when it comes to action, you can then use the WTO to proceed. But whether it will be ethical to proceed, those are the thoughts we're deliberating. So, we take your point, and we're looking at all sides of the issue to see, help to guide us how we ought to proceed. So, Karen says, no, the risk of disease in the country far outweighs the risk, and the country has an obligation to protect the health of the children. WTO can facilitate that, which is something that Colin was also saying. India says that we must have standards, quality laws, and protocol, looking at the legal aspect. And Claudia says that the country has to take some responsibility also. Yes. Karine says these countries should do what is best for their population. Can't disagree. So I think you get the general drift. So I go on to my answer. These resource-poor countries might be under legal obligation to honor these patent rights, but their moral and ethical obligations are more nuanced. In these circumstances, these countries will have to balance their obligations to the manufacturer against their obligations to the children in their local populations. And some of the responses that we just saw reflects this. In these circumstances, they have an ethical obligation to minimize harm. And when they have to choose between divergent paths that would increase health inequities between developed and less developed countries, and rich and poor communities, then morally they would be bound to prioritize the health of these children over the patent rights of the manufacturer. And so, in our discussion of this case today, we can see that deliberations that balance potential benefits against risk of harms are important justice issues in research ethics. We should note that a research ethics committee or a data and safety monitoring group may terminate a study prematurely to protect participants if unanticipated harm occurs. And you should be familiar with the various types of research study designs, and remember that the design is an ethical issue that may be just as important as balancing benefits and harms. And we should be clear in our minds regarding the role of a research ethics committee, the scope of its protection of research participants, and any role in the consequences that flow from research. I thank you for your thoughts, your ideas, and let's now open the floor for questions. Is there anything that we touched on that is not clear, that you would like us to elaborate on or discuss further? Or does everything fall in place in your reasoning? Well, there's a question we're going up further by Ms. Aberdeen. Is there oversight by the U.S. company in the local manufacture of vaccine? Yeah, that's a good question. The answer is no. Each country within its own jurisdiction has its own laws as to what happens in their own country. So the U.S., the Federal Drug FDA will license particular drugs that can be used there. Trinidad will have their own license by the Ministry of Health. Each country will have theirs. And that is where, in this particular case, this developing country thought that its population could benefit from this drug. And so it's mandated the local manufacturers to try and obtain the technique to be able to produce the vaccine for its own population. So, at the international level, that manufacturer can then, the WTO, which arbitrates these matters, and patents and so on, would arise at that level. But the US cannot come into, say, a Caribbean country and say you cannot. It has to go through the WTO or some other body that addresses international matters such as those. However, the manufacturer in the US can come to your country, to your court, and file an injunction there in your country against what you're doing. So there are two levels at which you can act. Going to the courts within your own country In other words, the US courts or the FDA cannot dictate to your country, but they can come to your country and raise an injunction, or they may moderate the matter, discuss the matter through the WTO. Pity we're not discussing case 17. We have to choose one. Petra. Sorry about that. We have a number of choices of what cases we discuss. We're trying to look at those that we think not only are relevant to us in the Caribbean, but may help to provide an increased knowledge in reasoning power for persons who may come across these issues in the future. And often it's a balance. Sometimes there may be 2 or 3 cases that fit that portfolio and we have to pick one. So, what I take your point. Can you explain double-blind trial? Oh, okay. So we're talking about research designs. Double-blind trial really speaks to what we call experimental research, where there is uncertainty as to whether one drug is effective over another. Usually it's a new drug recently developed versus one that may be existing in the society, which was thought to be partially effective but not totally so. So an improvement or a proposed improvement has come about, or a new drug, or there may not be anything available in the local population, in which case it may be pitted, it may be compared either against a placebo, meaning a dummy drug, or it may be pitted against what the local population used to use, a bush medicine or so on. Anyway, you have 2 arms where participants are enrolled randomly into a group that will get the new drug that's being tried, and another group that will get the comparison, be it an old drug or a dummy drug. And then you follow both groups to see how they respond to the new drug. You're trying to prove that there is benefit, a greater benefit from this new drug compared to the other. And so this is called a trial. You can have more than 1 or 2 comparisons. Usually it may be 2 arms, but you can have 3 arms. One person getting the new drug, one group getting what existed before in terms of bush medicine, and one getting placebo. So there are different ways of doing it, but that's what it is. You're comparing, and usually persons who are involved in each arm they don't know whether they're getting the actual new drug or they're getting the old drug. And so that's the way neither party know, and the researcher doesn't know, because they're trying to genuinely determine which is better. So that is the concept. But in research ethics seminars and training sessions, we go deeper into that, and I would refer you to any research ethics book that describes methodology, or enroll in any seminar, and we can go deeper into such issues. When making an ethical decision, do we always have to consider other elements outside of it? Oh yes, certainly. Everything comes to play in ethics. We are all interconnected, and all factors are interconnected. In the US, it depends, type of research survey, sample, etc., etc. Celia says, can we expand on ethical implications causing death in a well child that would not have died? Okay. I guess you're speaking there about the ethical difference. The fact is that if, let's look at 2 populations that they could have been referring to. In North America, rotavirus, because of their standard of living, rotavirus doesn't normally cause much morbidity, sickness or death in that population. And so when they got the vaccine and it caused interception, it was causing more harm than good. In some of our Caribbean countries, where rotavirus caused a lot more sickness and death, because we have less resources, then for us, more of the children are dying literally from the effects of rotavirus than from interception. And so that is where the ethics comes in. We're giving a drug, we're doing an action, so it carries an ethical implication. And so if we're giving it to a population where the 2 comparisons are between a healthy population and a sick population, and you don't think of standard of living or so on otherwise. That doesn't come into it. You're thinking of healthy and sick, then giving it today, it's going to cause risk of interception equally in both. However, if you then think of what is the effect that it's going to produce, which is it's going to help prevent death, then